Good evening, one and all, to the third presentation of Critical Care Medicine Forum. I am Dr. Shubham Kandare. I am clinical pharmacologist at Jupiter Lifeline Hospital, Pune. So till now, we have completed introduction to critical care. I'm sorry. Sir, am I audible?
Yeah, yes.
Is there any noise?
No.
No. Okay.
Came last time, yeah.
Okay. So I am Dr. Shubham Kandare, and I am working as a clinical pharmacologist at Jupiter Lifeline Hospital, Pune. So till now, we have completed introduction to clinical pharmacy in critical care unit, and also to the introduction of shock. So now we will move forward to the hypovolemic shock. So today's our speaker is Dr. Eldo Matthew. He is working as a clinical pharmacist at Specialized Rehabilitation Hospital, Abu Dhabi. He has more than 7 years of experience. He has completed his Doctor of Pharmacy from Kowai Medical College and Hospital, Coimbatore. His area of interest are antimicrobial stewardship, glycemic control in ICU, clinical toxicology, infectious diseases, drug interaction, and IV incompatibility. Sir, can we move to the next slide? So before going forward, we have some guidelines for the participants. So type your questions or responses in the comment box and click the submit button. All your question and answer will be discussed in the last of the presentation. So next slide, please. Submit your feedback below the comment box for your certificates. Next slide. After submitting the feedback, your certificates will be generated within 14 days of attending the event. Next slide, please. You can also download the slides from the FCPI website, but the login is mandatory for the download. Next slide, please. So I'll hand over to the Dr. Eldo for his presentation.
Good evening to all. Thank you, Shubham, for your wonderful introduction. We are going to discuss today hypovolemic shock. In hypovolemic shock, before that, I don't have anything to disclose. I don't have any financial relationship with any commercial interest. And these are the learning objectives. Analyze the vital science and laboratory results and the clinical manifestation of hypovolemic shock. Outline the initial management approach to hypovolemic shock in trauma, and discuss the management of hemorrhagic hypovolemic shock. So as in the name itself, it's called the low volume. Hypo means low volume shock. So we can classify hypovolemic shock mainly into two: absolute hypovolemic shock and relative hypovolemic shock. In absolute hypovolemic shock, there is actual loss of intravascular volume from the body. Where relative hypovolemic shock, there is a decrease in intravascular volume due to vasodilation or pooling of blood. There is a relative reduction of vascular volume relative to that apparent reduction of vascular volume relative to the vascular system, capacity of vascular system. So in absolute hypovolemic shock, we can find in hemorrhage or trauma, and in vomiting, diarrhea, and excessive diuresis or fluid shift. And where the related hypovolemic shock we can find in sepsis, anaphylactic shock, neurogenic shock, and medication-induced vasodilation. And in this figure, we can understand this absolute hypovolemic shock and relative hypovolemic shock in detail. And the first figure that VS is called the circulating blood volume, and VUS is unstressed intravascular volume. In the first normovolemia, so there is which will be 30% of stressed circulatory volume and 70% of unstressed intravascular volume. And in absolute hypovolemia, there is actual loss of intravascular volume. And in relative hypovolemia, the volume, the capacity of the vascular system is increased. So in order to prevent this, what we can do? We have to stop the hemorrhage in absolute hypovolemia. And so we can add volume into it, and we can use vasopressors in order to control this one, hypovolemia. So from the classification, so we can understand very clearly. Absolute hypovolemia shock, the blood volume will be low, and thereby the preload will be low, and the cardiac output become low, and the tissue perfusion will become low. So it leads to shock. In relative hypovolemia, the blood volume will be normal or near normal, and the preload thereby decreased cardiac output also, and thereby less tissue perfusion that leads to shock. So we can classify the absolute hypovolemic shock, hemorrhage and non-hemorrhage, trauma or hemorrhage, non-hemorrhagic burns, diarrhea and vomiting, and relative hypovolemic shock, septic shock, anaphylactic shock, and neurogenic and drug-induced. So in this presentation, we are going to discuss about absolute hypovolemic shock. Okay, there is a trauma and or hemorrhage. We are discussing the management. So what is the definition of hypovolemic shock? This is vascular volume rapidly and significantly decreased. Okay, these are mainly due to trauma, dehydration, burns, or surgery. So coming to the pathophysiology, there are two pathophysiology. We can classify pathophysiology, hemorrhagic and non-hemorrhagic. In hemorrhagic, the whole blood loss happened due to wound, and non-hemorrhagic plasma was drawn from the compartment. And there is because of burns, pancreatitis, or third person peritonitis, or diarrhea, or vomiting. And this leads to reduced intravascular volume, or we can tell it as a reduced preload. And this further leads to reduction of stroke volume and cardiac output. And it further leads to inadequate tissue perfusion, and finally shock. And coming to the diagnosis of hypovolemic shock, the clinical features of hypovolemic shock include hypotension, which is a hallmark of shock, and tachycardia. The body is attempting to compensate the decreased blood volume, and the skin will be pale, cool, and clammy. Skin is because of peripheral vasoconstriction, and weak or absent peripheral pulses because of the reduced perfusion. And the altered mental status is, we can find confusion, agitation, or loss of consciousness because of reduced perfusion to the brain. And other features include there will be compensatory mechanism to encourage the fluid intake, and the urine output will be low because of reduced renal perfusion. We can find either oliguria or anuria. Coming to the diagnosis, hypovolemic shock. So the cardiac index will be normal, and the preload will be low. So the pulmonary capillary bed pressure will be 8 to 12 milligram per mmHg, and afterload will be normal, and the tissue perfusion will be low. And the complications of hypovolemic shock, we can find it can lead to acute kidney injury and coagulopathy, acute respiratory distress syndrome, multi-organ dysfunction syndrome. Coming to a case scenario, in this case, one patient, 35-year-old female, called SA, admitted with complaints of weakness and dizziness, and she had a history of car accident with a sustained deep laceration on her leg. And while coming to the emergency, she is complaints of weakness, dizziness, feeling lightheaded. And later the wound was there was a bleeding from the wound, which was uncontrolled, and she doesn't have any past medical and medication history. And coming to the vital signs, and her BP was 80/50 and a MAP of 60 mmHg, and heart rate 120 beats per minute, and a respiratory rate of 24 beats per minute, and oxygen saturation in 92 early. On physical examination, her skin was pale and clammy. That shows the reduced perfusion, and the pulse was rapid and weak and cool extremities. So there is a compromised perfusion, and the urine output was 30 ml per hour. That is after catheterization, and there is a blood loss. The noticeable blood loss was there from the leg wound. And the diagnosis test, they underwent hemoglobin and hematocrit and other tests also. And there shows it showed significantly decreased HB and hematocrit, indicating loss of blood. And so the essay who we can discuss a few questions. And essay who has experienced 45% of loss of their bloody fluid and experiencing hypovolemic shock, and she has a hemodynamic monitoring and fluid resuscitation is being attempted, and which indicates the patient is still hypovolemic shock. So we have 4 options: low central venous pressure, high pulmonary artery wedge pressure, elevated mean arterial pressure, low systemic vascular resistance. So what will be the answer? So high pulmonary artery wedge pressure won't be there, and elevated mean arterial pressure won't be there since the patient is on shock, and low systemic vascular resistance or low central venous pressure. So mostly what will be the answer? So central venous pressure. So we have static and dynamic variables. Okay. So static variables are measure the current state of hemodynamic system, where the dynamic variables measure the responsiveness of system to therapy. So the pressure variables and the static variables can further classified into pressure variables and volume variables. In pressure variables, we can find central venous pressure, occluded pulmonary artery pressure, and volume variables include left ventricular end diastolic volume, left ventricular diastolic volume. And dynamic variables we can classify into pulse pressure variation and systolic volume variation. So in this case, so the current status of the hemodynamic system can assessed by static variables, where we are using the central venous pressure. So the normal range is 8 to 12 mmHg. So the central venous pressure is has the ability to it indicates the state of the hemodynamics of the patient. So usually the usual range is 8 to 12 mmHg. So in shock, it will be less than that. So we can identify that. Even if some cases there are limitations for this if the patient is ventilated, and for other issues there are limitations. In dynamic variables, the pulse pressure variation we can assess. So in this case, the appropriate answer is central venous pressure. So I'm not going to discuss details in this, and in upcoming presentations we will go with that. And coming to advanced trauma life support, as we heard about ACLS, advanced cardiac life support, there is advanced trauma life support also. Those patients underwent trauma. In order to reduce the mortality, we have to react quickly. For that, American surgeons introduced this ATLS. So in this management of hypovolemic shock due to trauma, there are primary survey and secondary survey. So we have to evaluate the patient quickly. And coming to the primary survey, in this primary survey, we are analyzing the airway of the patient. If you are able to talk to the patient clearly, the patient is respond to verbally clearly, so we can understand the patient breathing pattern and the airway is not obstructed. So if is any obstruction we found, we have to rectify that, and we can give the spine collar also if there is a suspicion of spine injury. And the breathing we can find while patient is talking to us, and if the patient is not willing to talk or not able to talk, we have to find the reason and we have to rectify, and we have to give sufficient oxygen. And this chronic cases, we have to ensure 95% above oxygen saturation. We have to ensure that. And coming to the circulation, we have to ensure that secure the venous access, large bore, 18 gauge size we used to keep. And we have to do the cross matching of blood, and we have to send an investigation of creatinine, ABG, and we have to take action to control the bleeding, external bleeding, if any bleeding. And the disability, we are checking the neurological status of the patient. We can check the Glasgow Coma Scale, and also we can check the alertness of the patient, to vocal stimuli and the pain stimuli, and if the patient is unresponsiveness, so we have to assess the patient sensorium. And also we can check the GCS, so we will get an idea about the progression of the shock. And coming to the exposure and the environment, while undressing the patient, we should ensure the patient is not going for hypothermia. We have to maintain the hypothermia. While we are undressing, the patient is to search for any other hidden trauma or hematoma. And coming to the adjuvant, so we have to, if patient having any trauma, we have to investigate the chest X-ray in order to rule out pneumothorax or hemothorax, and pelvic, any long bone fracture, any pelvic fracture, and lateral C-spine we have to take to rule out any C-spine fracture is there. And the AP view won't give that much idea about it. So the BP and the heart rate will not identify all trauma patients who are in shock, which will be late. So the BP will drop and heart rate after bleeding. So we should not rely on this BP and heart rate, and we have to assess the patient history. What is the mode of injury and the perfusion interest, saturation of the patient we have to check, and the ABG, the blood gas analysis, and base deficit, lactate, hemoglobin, and hematocrit. Why? Because any trauma, there's a chance of getting hyperperfusion. This can lead to anaerobic metabolism. So in anaerobic metabolism, there is a production of lactate, which is the end product, and which can lead to metabolic acidosis. Okay, and there is accumulation of lactate, and the base deficit also we can find. After, if you are able to find the reason for the trauma, if you are able to rectify that, then we can go for the secondary survey. And if patient has still have signs of shock, and we have to evaluate the person, the source of hemorrhage we have to identify. So we have to review the careful inspection and all over the body, and any hematoma, signs of hematoma, any blood is leaking from anywhere, and we have to check any long bone fracture, and we have to check the X-ray if any pneumothorax or hemothorax, okay, any cardiac tamponade, any this one. So we have to evaluate. And abdomen fast we can do, and diagnostic peritoneal aspirate also we can will get an idea about any internal bleeding is there. And the retroperitoneum also we can check with the X-ray, and if there is any hematoma we can find. And the interventions we can do is we can the suture laceration, we can prevent the wound, the bleeding we can prevent, and the long bone fracture we can use the splint and the test tube. If any hemothorax, we can insert test tube, and we can relieve the the blood, and as well as the air from the chest. And the abdominal, any laceration or abdominal, any bleed, internal bleeding, we can do for any laparotomy immediately. And retroperitoneum, we can stabilize the pelvis, and emergency angiogram we can do. And in case of uncontrolled hemorrhage, and aliquots of blood fluids we can give. And so in order to maintain the BP 80 to 90 mmHg, and we should take care of the elderly population, and unconscious patients with a palpable blood pressure we have to take care. And we should maintain the blood pressure of more than 90 mmHg with the traumatic head injury. So we need high systolic pressure we have to maintain for the traumatic brain injury. So coming to the secondary survey, this is after the primary survey we can do once again if we are not able to find the reason for, if the patient is not we are not able to control the bleeding, or if the patient is not responding, so we can do primary survey again. Once the primary survey is finished, we can go with the secondary survey. In the secondary survey, we are evaluating the patient's history of allergy, the health history assessment we are doing, where we can find the allergies of the patient, if patient had any allergy, and medications currently used. It's very important because if patient is on any anticoagulants, so it has impact on this trauma. So we have to identify what are the medications was on patient, and the past illness, any cardiac issues, any renal failure. So there is some if you're giving too much of colloids or any fluids, so it has some issues. So we have to check the past illness, and if any pregnancy, we have to take care of the fetus also. And the last meal, the patient had any spinach or something like that, so it has impact on this. And events of environment into the injury, any other exposure, any patient is exposure to any type of vesicants or other aspirant, so we have to evaluate that. So this is how we are approaching a patient with the trauma. Coming to the management of hypovolemic shock, so goals of improving physiology, we have to maintain the normothermia, and we have to minimize the coagulopathy, and the next step will be the stopping of bleeding. So we can do the interventions to stop the bleeding, and we should have a blood pressure goal for the penetrating wound, blunt trauma, and brain injury. And the fluid challenge we can do, and the first line treatment will be fluid resuscitation, and the second line will be vasopressin. Antifibrinolytics, tranexamic acid we are using. These agents inhibit the breakdown of blood clots, thereby clot formation, the dissolution of clot formation is prevented. So it's bind to plasminogen to prevent the dissolution of fibrin clot. And also in CRASH 2 and CRASH 3 trial, CRASH 2 trial conducted in 2010, and there is early administration of tranexamic acid within 3 hours of injury reduce the mortality in trauma patient. Whereas in CRASH 3 trial in 2019, there's a beneficial in reducing the mortality in patients with a traumatic brain injury when administered early after injury. So it has a good impact on the controlling of the bleeding. Coming to the reversal agent, if we have a history of patient taking these medications, if the proper intervention, early interventions can reduce the mortality of the patient. So drugs for heparin, we can use vitamin K and prothrombin complex concentrate. Heparin, prothrombin sulfate, we can use, and the molecular weight heparin, prothrombin sulfate. And direct oral anticoagulants, apixaban, rivaroxaban, we can use idaruximab, antecedent alpha, and for PCC. And dabigatran, we can use idaruximab. Aspirin, we can use platelet transfusion for the blood clotting. So desmopressin and PCC. And clopidogrel, again, we can use platelet transfusion and desmopressin and glycoprotein 1, 2B, 3B inhibitors, tirofiban, epifiban. And coming to the special goals, the blood injury, blood trauma or injury, that is because of normal vehicle injury or fall injury belongs to blood injury. So our systolic goal will be 80 to 90 Hg. Once the hemorrhage is controlled, we can fix the higher goals. And brain injury, we have to measure this one, maintain blood pressure or systolic blood pressure of 100 to 110 mmHg and the map of greater than 70 mmHg. And penetrating trauma, this is because of gunshot injury, so missile shell injury. So in this case, we have to maintain of blood pressure goal of 50 to 70 mmHg. In this case also, once hemorrhage is, we are able to control the hemorrhage, we can fix the higher goal. Coming to the another question, if SA has a blood volume of 5 liters and losses 2 liters, what is the percentage amount of blood loss in this patient has experienced? So we can easily calculate it. So there's a 2 liters loss out of 5. So we can calculate easily, and the answer will be 40%. So coming to the classification of hemorrhagic shock, based on this blood loss, percentage of blood loss, we are classified into, we can classify hemorrhagic shock into 4 classes. Class 1 up to 75 ml of 750 ml of blood loss, and class 2 is mild hemorrhagic shock, where 750 to 1000 ml blood loss was there, and class 3 1000 to 1500 ml blood loss, and in severe cases class 4 more than 2 liters of blood. And coming this one, we can find the heart rate. So the management in the class 1, the mental status will be slightly anxious, and the initial fluid is crystalloid only. In mild case also we are using the crystalloid, but in case of third class, so the patient, we have to give crystalloid as well as blood. And severe cases, we should not wait, and we have to react quickly with the crystalloids and the colloids. So what are the IV fluid resuscitation strategies in a trauma patient? The patient had a major trauma, and we have to give 1 to 2 liters of crystalloid or clear colloid we can give. And we can categorize into 2 categories mainly, non-responders and responders. If patient is responding and is non-acidotic, having normal temperature, the crystalloid, judicious use of crystalloid is only enough for the treatment. And the responders and who is on acidotic and low temperature, we have to transfuse the red blood cells. The acidotic, this one is a marker of the loss perfusion. So we have to give more blood to the patient. Then only this one, the oxygen will reach the blood side, as the tissue perfusion will be adequate, and the acidosis will become neutralized. And we have to consider the source control also. And coming to the other class, the non-responders, if patient is non-responded to the fluids and no source control, still on bleeding, and is acidotic and having low temperature, we have to go with the massive transfusion. And if the same class, the non-responders having no source control but non-acidotic and normal temperature, we can go with the blood transfusion. And if this patient, once we given the blood transfusion not improving, we have to go with the massive transfusion protocol. If after giving the adequate blood to the patient and the patient has good response, we can go with the crystalloids. So SA is receiving large amount of fluids for aggressive treatment of hypovolemic shock, which makes it priority. So the options are rapidly infuse the fluid, warm the fluid, change tubing in between bags, keep the patient supine. So we have to ensure the warming of fluid. Coming to the massive transfusion protocol, typically 1:1:1 ratio red blood cells, platelets, and fresh frozen plasma. RBCs we are giving in order to improve the oxygen carrying capacity. Only the red blood cells have, and the platelets we are giving for the clotting. The clotting factor and the clotting factors available in fresh frozen plasma. So this ratio we have to maintain. The additional factors, blood factors we are giving, and fibrinolytic factors, we already discussed the tranexamic acid, and also desmopressin also available. And calcium we are giving, which is one of the clotting factor, as well as we have to the stored blood, there is a chance of hyperkalemia, we have to relieve that one, and also the preservative citrates will be there. In order to utilize that one, we have to give calcium supplement. And the blood warmers are very important to avoid the hypothermia that leads to coagulopathy. So the blood warmers should be there. And electrolyte management we have to do. And coming to the blood products, the RBCs we are mainly for the tissue perfusion. Oxygen carrying capacity is our goal. So in order to improve the tissue perfusion, oxygen perfusion, we have to give the red blood RBCs, and the platelets for the clotting, platelets for the blood clotting, and FFP for the clotting factors, and PCC, and there is a combo clotting factors 2, 7, 9, and 10, and with other proteins, protein C and S, which is helping for the blood clotting. And for PCC is the same as PCC. Composition is similar to PCC with the clotting factors 2, 7, 9, and 8. And clear precipitate contain high concentration of fibrinogen, and the recombinant factors 7A is a synthetic form of clotting factor. And coming to the choices of fluids, we have crystalloids and colloids. In crystalloids, we are usually go with the sodium chloride and lactase ringers and balanced electrolyte solution, plasmolyte. And colloids, modified gelatin, dextrans, albumin, hydroxy starch, and RBCs. Comparison of fluids. So if you're comparing these colloids, the composition, the crystalloids contain small molecules, where the colloids contain large molecules, volume expanding properties, intravascular, and the crystalloids has capacity to expand the intravascular volume and extravascular volume, and where the colloids has only expansion of intravascular volume. So osmolarity of crystalloids is similar to plasma, but in colloids they have higher osmolarity. And indications of this crystalloids we usually give for the hypovolemia, dehydration, or perioperative care. And the colloids we are giving in severe hypovolemia, burns, and the rapid oleum expansion is wherever required. And the adverse effect of the crystalloids include fluid overload, because 35% of the fluid will retain on the intravascular compartment. And if you're giving too much of the sodium chloride, there is a chance of hypochloremic metabolic acidosis, and dilutional coagulopathy chances are also there. wherein colloids, the status can cause coagulopathy, and anaphylaxis reactions is common in gelatins. And if you're giving too much of colloids, there's a chance of getting renal dysfunction as well. And cost effectiveness, the preserves are less expensive, where the colloids are more expensive. So we already discussed the examples. So in the meta-analysis and systematic reviews, there is no evidence that colloids is superior to crystalloids for fluid resuscitation in patients who are traumatized, having burns, or recovering from surgery. There is no mortality benefit, or there is no the pulmonary edema or length of stay. There is no difference. We cannot differentiate. So the crystalloid resuscitation may be associated with the lower mortality than colloids in trauma patient to avoid the renal injury. We will in the upcoming slides we will discuss in detail. And coming to the vasoactive agents, so after giving the fluid, adequate fluid resuscitation, the patient is not BP is not improving, or the perfusion is not adequate. We have to start vasopressors. So and the inotros, if it is required, we can start. And the vasopressors coming to noradrenaline will be the first option, and the 0.05 to 0.1 microgram per kg per minute will be the dose. And vasopressin, next vasopressin is not improved, and then adrenaline, dopamine, and phenylephrine we can use in patients. So where the receptors are located and what is the action. So alpha-1 receptors we can find in vascular smooth vessels. So we have to construct the blood vessels. So the smooth vessels. So we have to reduce the vascular capacity of the blood vessels. So thereby we can improve the blood pressure. And alpha-2 is centrally located, beta-1 present in the heart, and beta-2 in the lungs, and the dopamine receptor in the renal and mesenteric and coronary beds, and the vasopressin receptor we can find in vascular smooth muscle, and the vasopressin V2, V1 in the vascular smooth muscles, and the V2 in the renal. So coming to the receptors, the adrenaline, which is acting on alpha-1 and beta-1, and it increase the cardiac output and systemic vascular resistance. Noradrenaline, it has the activity more in alpha-1 compared to beta-1. So increase systemic vascular resistance, but there is that much not that much effect in cardiac output. And dobutamine, there is an effect in beta-1. It increases the heart rate, cardiac output will increase, and there is less effect on systemic vascular resistance. And coming to the dopamine, there are 3 doses are there. 0 to 5 microgram, there is effect on dopamine receptor. This is for we are using for the improve the renal perfusion. And 5 to 10 microgram per kg, there is effect on beta-1. It increases the cardiac output, and higher dose 10 to 20 microgram per kg per minute, where we can the systemic vascular resistance will increase. And phenylephrine, if we consider when the patient has tachycardia or arrhythmia, we will go with the phenylephrine, where the activity only in alpha-1, and it will increase the systemic vascular resistance. Come to vasopressin. First choice, as I said, the noradrenaline will be the first choice, and second, we can use vasopressin. It will potentiate the effect on noradrenaline. It act on B1 receptors and cause vasoconstriction. Thereby, we can increase the blood pressure. And if the dose more than 0.03 units per minute can cause tissue ischemia. Peripheral ischemia will be the complication. Coming to the next question. Essay with the hypovolemic shock is need of clotting factors. Which type of fluid will be best in this patient? Platelet only. Clotting factors won't be there. Albumin, packed blood cells. Okay, so the answer will be fresh frozen plasma, where the clotting factors are present. So coming to the landmark trials in the fluids. So the SAFE trial, which is conducted in 2004, where the saline versus albumin fluid resuscitation, which the randomized control trials conducted in centers internationally, and they examined the effect of albumin versus 4% albumin versus normal saline, and they couldn't find any difference in the findings, and there is identical in the result found in 28-day mortality, ICU length of stay, hospital length of stay, length of mechanical ventilation, and days of renal replacement therapy. And some discrepancies and controversies existed till in trauma and severe sepsis and brain injury cases. There is no significant difference in any of the predefined subgroups. That is include trauma, severe sepsis, and traumatic brain injury. And coming to the tested trials, crystalloid versus hydroxylated starch, and which is a multi-center trial where there is a 7,000 patients underwent the trial. There's a comparison between hydroxylated starch and normal saline, which is conducted in 2012, and there was no significant difference in 90-day mortality. And if you're comparing this for hydroxylated starch group had a greater need of renal replacement therapy than normal saline group. Coming to the another trial, which is conducted on 2013, crystal trials, where there's a comparison of crystalloids and colloids, and there was no difference in 28 days mortality. However, there is a 90-day mortality was significantly lower among the receiving colloids. The use of colloids and solutions are preferred choice for fluid resuscitation in critical patients. Though this trial can and we have to further evaluate. So as per our knowledge, the crystalloid solution and the colloids have same effect on the fluid resuscitation. The volume, liberal and restrictive. So systematic and meta-analysis conducted. So they already evaluate the use of liberal and restrictive fluid. So liberal fluid resuscitation associated with a high incidence of acute lung injury and ARDS, but there is no clear superiority of either volume liberal or volume restrictive fluid resuscitation strategy in trauma patients with a hypovolemic shock. So the restrictive and there is no clear-cut differentiation. But we can, if we are restricting the fluids, we can avoid the complication of acute kidney injury and the ARDS. And the timing of resuscitation and the liberal use of isotonic crystalloid to correct hypotension. And there is no clear-cut recommendation in Cochrane review also. There is no clear-cut evidence. And in the ATLS protocol, they are suggesting the liberal use of isotonic crystalloid to correct the hypotension. The early initiation of fluid resuscitation is essential to prevent the hypovolemic shock. And but we should careful about the titration and monitoring as to avoid the complications associated with the our fluid resuscitation. And the vasopressors depend upon the patient factor. Noradrenaline will be the first. After giving the adequate fluids, the patient BP or blood pressure is not improving, the tissue perfusion is not able to achieve, then we have to initiate the noradrenaline, which can increase the systemic vascular resistance as well as increase the blood pressure. And vasopressin is the adjuvant therapy in refractory cases, and the adrenaline it will be the another option if not improved with the other agents. Coming to the key takeaways. So as we studied hypovolemic shock, there is a pure perfusion due to lack of intravascular volume, and we have to underline the cause of hypovolemia, control the bleeding, and replace the fluids and the crystalloids. And we have to consider adjuvant therapy such as blood transfusion in order to the oxygen carrying capacity, and the fluids alone is not a good option to improve the outcome. we can use vasopressors and inotropes as needed if it is required, and blood pressure and heart rate will not identify all trauma patient who are in shock. So we have to review the patient. We have to identify the cause of the blood loss and and we have to monitoring the parameters in a serial manner. We have to check frequently. We should not rely on the first value. We have to check serial series of these investigations, hematocrit, PT, PTT. We have to evaluate, and also the how we are identify the outcome of the therapy. The response is urine output. So initially the fluid we used to give 30 ml per kg we can give. Usually 1 liter we can give for the adult patient and 20 ml per kg for the pediatric. So the urine output should be 0.5 ml per hour in adult and 1 ml per hour, 0.5 ml per kg per hour in adult and 1 ml per kg per hour for pediatric. And we have to, if patient is underwent any deep laceration, we have to think about adding the T2 vaccine also. So if patient clean wound, we can consider the tetanus toxoid. And if it is contaminated wound, or we have to consider tetanus toxoid as well as tetanus immunoglobulin. And we already heard about the spleen injury. If patient splenectomy, then after 2 weeks, we have to give pneumococcal, meningococcal, and H influenza vaccines. These are my references. Coming to our next presentation, these are our next presentation in upcoming weeks. April 14th, penetration of in ID forum, and top uppers in critical care medicine on 16th of April, and transplant. There is a podcast on 19th of April. And the 20th of April, there is a ID forum basic module. And on April 21st, there is a discussion about basics of evidence-based medicine, part 1. Thank you. Over to Shubham.
Thank you, sir. Thank you for your wonderful session. So we have some questions. So first question is, you have seen many patients in ICU. So what is the role of clinical pharmacist in managing the hypovolemic shock patients? So what parameters should we look for?
So we have to identify the patient on shock. The primary survey is underwent properly. We have to evaluate that. And after that, we have to analyze whether the patient is having received the adequate fluids during the first resuscitation time. And also hypovolemic shock, there will be any hemorrhage. We have to identify the source of the bleeding. So if it is a deep-seated wound, so the source control will be the first priority, though, and also any antibiotic prophylaxis we need to give, that we have to ensure, and stress ulcer prophylaxis, because there is a sympathetic surge will be there, so there is a chance of getting stress ulcer. So we have to use stress ulcer prophylaxis for this patient. And if this patient having any the fluid resuscitation, so adequate fluid is received after the investigation is sent properly, and we have to evaluate any antibiotic prophylaxis already done. And if it is any requirement of inotropes, we have to ensure which will be the choice, and we have to ensure we have to check any patient had any history of allergy, medication allergy. So we have to identify, or the patient is came with a hemorrhagic shock or trauma. The patient had receiving already the past medical history. We have to check with the family. But it's a very few cases we will get the history from patient. The patient is awake. Otherwise, we have to check with the family any medication. So we can reduce the mortality by knowing any drugs. So we can guide the physician for the reversal of these medications, and it will reduce the mortality of the patient.
Right. Thank you, sir. So next question is, so while using the vasopressors, when we should use the vasopressor upfront with the fluid resuscitation or after fluid resuscitation?
After fluid resuscitation, we have to, if we are not able to achieve the adequate perfusion, we have to check the urine output. If it is less than 0.5 ml per kg per hour, for adult patients, so we have to consider, we have to find the source of, where the fluid is leaking. So if any other hemorrhage is ongoing or any hematoma is ongoing, so we have to find. If we are not able to find anything, then so we have to start the vasopressors. Normally, noradrenaline we have to start, and later, if not improving with the noradrenaline, we will go with the vasopressor.
Okay. Thank you, sir. Thank you so much.
Thank you, Shivam. Thank you.